surgery, but
Luckily,
I
I didn't
love
put
it.
on the same shirt.
Oh, are you? I couldn't even tell. That's so
No,
funny.
I hesitated. I hesitated. Nice.
All right. Well, thank you everyone for joining our project. This is basically my teammates, Justina, Tejasvini, Yusra, and Andrea. We're all in this program with Dior and UNESCO called Women at Dior, where we were tasked to identify an area, particularly for women, that we feel like could improve in society and create a project around it. So our project is called Rose Et Fière, and our goal is to help women take charge of their own health and advocate for themselves. Ultimately, we want to be able to offer a volunteer service where women can request an accompanying person for healthcare appointments to help them advocate for themselves and with language barriers and stuff like that. And also have a set of doctors we really recommend starting out in Paris, but we'd love to expand as well. Super excited to chat today. We were really inspired to start this project because I had a little cancer scare in 2023, which ended up being nothing, thankfully. But I decided to have a double mastectomy alone in France in 2024 to be proactive because I have the BRCA gene. And 5 surgeries later, thanks to Kim, my risk of breast cancer is down to the single digits. I'm really happy with the choice I made and the support I have. And I feel really honored to have her here, and Jenny too, to talk about all things breast cancer. And I can't say enough about how great my experience was. If you want to go to the next slide, I think we have an intro to them.
Well, fancy.
Yeah, fancy. So we have, oops, we have Kim, who's special. Do you guys want to talk about yourselves at all? Like, is that maybe that's better? You
Well,
want to do a little intro to you?
well, if you want, that's a bit
Yeah, do
weird.
it. Go for it.
I'm Dr. Kim de Fremicourt. I'm a plastic surgeon at the Institut du Sein, Paris. It's a breast cancer center with Dr. Jenny Millochau. And we specialize in breast reconstruction, cancer treatment also.
Okay,
Jenny?
amazing.
Ah, well, I'm a gynae first, but I specialize in breast cancer and reconstruction.
Yep.
So I work now with Kim at the Institute of Paris, Breast Paris.
Hmm.
Amazing. Okay, perfect. We came up with questions that I feel like are basic, good to know. And yeah, if we want to go to the next slide, let's see. For people who are just trying to prevent breast cancer, are there things you should be looking for, lifestyle habits you recommend keeping or letting go, and like what kind of tests you can do?
So I'll start with the symptoms, which is quite easy actually. You can see if your breast has some changes, like the shape, the size, the skin also can change. You can have some dimpling, which can look like an orange peel, some inflammation. You also have to check your nipple. If there's a sort of retraction, like an inversion of the nipple, that can be a sign of cancer, or some discharge, which is some like liquid coming out of the nipple, especially when it's bloody. Try to look also for masses, lumps in your breast, in your underarm area also, which are the lymph nodes, and also if you have pain, chronic pain in the breast and in the armpit area too. So that's one point. You can do the self-exam quite often if you want, without, of course, being paranoid, but try to look like once a month to see if you notice any changes. For the lifestyle habits, of course, I would recommend a healthy lifestyle, which is a regular activity, physical activity, about like 2 hours and a half per week. You can fraction it, of course. You don't need to do everything in like one time. Um, Try not to have a sedentary lifestyle every day. Try to walk, go to your work, like walking, cycling, take the stairs, whatever you can do, whatever you can take. Do some physical activity. That's super important. Other thing also is the food. Try not to eat too much sugar, too much fat. Eat like vegetables, fibers, fruits, grains, whatever. Try to not have processed food and try to make the food like your meals yourself. That's more health. It's healthier actually. And of course, most important is no tobacco. Do not smoke, not try not to smoke, like do not smoke. That's the worst you can do to yourself. And try to limit also alcohol consumption. That's
Okay,
it
beautiful.
for self-examining screening.
Yeah. For self-examining, so you can do your self-exam each month after a period. You can start at 20 years. After at 25, you can start examination with a doctor, like a gynae. You do each year the examination, and after when you are 50 in France, we recommend to do the follow-up with mammogram each 2 years in order to diagnose early a cancer if there is a cancer. And just
Perfect.
to give an information,
Mhm.
your lifestyle, sorry, is very important because you can reduce your risk like 30% if you change your life habits.
Mm. Yeah.
So it's very important.
So important action on that point
Mm.
that you can do. And not only
That's
for
great to
cancer,
know.
for all the other diseases, of course.
Yes, okay, that's great to know. That you have, yeah, 30% is so high that you can
Yeah,
reduce
it
it by
is.
that much.
Mm.
Wow. Do we want to go to the next slide? Let's see. Oh,
So
yeah, okay, perfect.
if there is a suspicious lesion, what tests are necessary? We will start by a mammogram and an ultrasound. They will have a look, they will describe if it's a suspicious lesion or it's a benign lesion, because when you are young, you can have some lesions very benign, like adenofibroma or cyst, or it's frequent. Okay, so don't panic if there is anything on your ultrasound, on your mammogram. Most of the time it will be benign, but you have to check with the radiologist. And if there is any suspicious lesion, they will do a biopsy. And only a biopsy can confirm there is a cancer. Okay, so we can't tell to a patient there is a cancer without any biopsy. If there is any doubt, especially in young patients, the radiology will ask an MRI, because MRI is very has a good sensibility for young patients with a dense breast.
Mm. Yeah. So when you're young, like more MRIs are
Yes.
recommended. And just maybe to for the patients, biopsy is when you take a little specimen from the breast. You know, there's a radiologist that will take a sort of needle, quite a big one, but okay. And then we'll take a sort of a sample of it. We'll analyze it in the with the anatomopathologist, and that will see if it's a cancer or not. It's by looking in the cells that you can see. It's not only like the imagery.
Yes, I've had that done, and it's also less scary than it sounds, I feel like. Like they numb you, and
Yeah,
there's very minimal bruising. So if you are in that situation, don't be too afraid.
yeah, exactly. It's like a big blood test in your breast.
Exactly. Okay, perfect. What are the next steps if they do detect something?
Mm.
There's
What are
a
the next step? If there is an abnormal test results, but we will discuss about these results. Is it benign and we can only remove, or is it a cancer? And we have to discuss about the type of the cancer, because each cancer has different treatment. Some are treated by surgery only. Some by surgery, when we do a lumpectomy, remove only a part of the breast and not the total gland of the breast. If we keep the breast, you need after radiation if it's a cancer. And for some cancer, aggressive cancer, for example, triple negative or other type, we might need chemo. Chemo is done before surgery or after surgery. the aim of the chemo before surgery is to see the answer of the lesion to the chemo, and in some case to keep the breast, which was impossible before the chemo, because the chemo can reduce the size of the cancer. After the choice, if we need chemo or not, if we do a surgery, if we can keep the breast or not keep the breast, and if the radiation is necessary or not, it's systematically necessary when we keep the breast, and in some case when we remove the breast, especially if there is an auxiliary disease. Because when we do surgery for cancer, we check the breast, but also the lymph node. Okay. And after this different treatment, the patient might have some treatment by hormonal therapy if the cancer was hormonal dependent, if the cells of the cancer have a sensibility to hormone, we can put this treatment to avoid a recurrence. It's very important because it reduces the recurrence by 2. So it's a very important treatment for patient to prevent, to avoid a recurrence.
Yeah.
That's it, I think.
That's not bad already. So actually, yeah, it really depends on the type of cancer that we will have.
Yes, because often the patient are scared when we say cancer, when they heard the word cancer, but they have to know there is very different type of cancer, and each type has its treatment. So you can't compare your cancer to the cancer of your sister or friends. You have to know exactly what is the type of your cancer.
Yeah.
That is really good to know. Do you guys
Yeah.
want to go to the next slide? I think it might be covering the things that
maybe.
we were just talking about. Let's see.
Treatment
Yes, I
option.
think we went through that, some of that.
Yep. Exactly. So now the
side effects. Yes. So the side effects for surgery can be pain, can be swelling, change in the breast aspect, and scar because it's surgery. For radiation, the skin can be different. They can be a little red, like if you go to the sun.
Yeah, like some big sunburn.
Yes, and the texture can be different, a little harder. For the chemo, we know the side effect. All of you have seen a film or something. You can have nausea, you can lose your hair, there is fatigue, and an increased risk of infection. For the hormonal treatment, the most often patient has hot flashes and mood swings and fatigue, and some gain of weight.
So the hormonal therapy is like induced menopause.
Yes, it's like
sort of.
induced menopause. It's reduced the sensibility of the cells to the hormone. So there is some change like menopause. But it's I repeat, but it's an important treatment to prevent a recurrence. So we know there is a side effect, but we try to avoid them, and to avoid them, the physical activity is very important. So it's important for the tolerance of the treatment, but it's important to avoid the cancer first and to prevent a recurrence also. So really, physical activity is important for all these aspects: treatment, prevention, and avoid a recurrence. For the surgery, perhaps you have seen some long time side effect, like a big arm called lymphedema. It may occur when you have an axillary dissection only, not a sentinel node. But you see in medical books, or you can see a lot of pictures on internet, and it's the worst side effect of axillary dissection for us, and can be very gênant.
I think
Can be, sorry for my English, can be very
Bothering.
for the patient.
Daily, yeah. Okay. Maybe we pass to the next question, like what is a mastectomy? Jenny informed you a little bit earlier what it is. I think we can say that there are like two types of surgery. There's the total mastectomy where you take out actually the whole gland of the breast, like take out the whole breast. You can also keep the skin in some conditions, of course, which is immediate breast reconstruction. The indications of a total mastectomy is when the cancer is too big to keep the breast, or if there's an inflammatory cancer, or also if it's a prophylactic surgery. You also have to take out the breast when there's a multifocal cancer too.
Just I can add, but it's important you can't compare your surgery choice with your sister, for example, because if you have a 2 centimeter lesion in a little cup of the breast in a A, we can't keep the breast.
Exactly.
If you have a 2 centimeter of lesion on a D, you can keep the breast. So it's very important to know it and to
understand.
To understand. In a cancer, it's a personalized treatment.
Yeah, exactly. And the other treatment which we talked about is the lumpectomy. That means that it's a partial mastectomy, or other name, is where you can take part of the breast out. So that's usually quite a small cancer compared to the size of the breast. And what we can do also is a sort of oncoplastic surgery, which we do in our cancer center. We use some techniques of plastic and aesthetic surgery, like breast reduction, to also remove the cancer and also lift up the breast to avoid a sequela, like aesthetic sequela, especially after radiotherapy. So that's very important for us also. We can talk about the different types of reconstruction, maybe. So there's several types of reconstruction. Maybe you saw that quite widely on the internet also. We talk about it quite often. We can say that there's like two types of reconstruction, like implants, silicone implants, which is the most used one actually. It's quite simple. It's fast to do, but you have to have the skin loose enough to allow us to put an implant under the skin. Also, like it's a foreign material, you need sometimes to change the implant. It has some maintenance. So you change it if there's a rupture of the implant or a capsular contracture. The other type of reconstruction is autologous. That means only by the tissues of the patient. And there's no foreign material, so no maintenance for surgery. The two types are flap and lipofilling or fat grafting. The first one is the flap. That means you take tissues from another part of your body, like it could be the abdominal wall, which is a Dieppe flap, or the thighs. So it's a tug flap. You need microsurgery for that. And you can bring healthy skin, some volume also to the chest wall. And we use those flaps, patient's choice, but also if we cannot do a reconstruction by implant, when the skin is too tight, you cannot tuck anything under it. So you need to bring healthy skin. The other type of flap that is widely used is the LD flap, which is the latissimus dorsi flap, is what we take in the back. So you take the muscle and the skin in the back and transfer it without microsurgery to the chest wall. And we were talking about fat grafting. Fat grafting is when you take fat by liposuction wherever you want. It can be like the abdominal wall, your thighs, your hips, wherever you want us to go, we can take and transfer it to the breast. So we can do exclusive lipofilling, which is reconstruction, autologous reconstruction just by fat grafting. And you need like 3-4 sessions, maybe more sometimes, to have a sort of like B or small C cup. So that's the principal types of reconstruction. And what we do in our cancer center is composite reconstruction, which is we mix the lipofilling with the implant, and we do that in one single session. We will inject the fat under the skin and on top of the implant to thicken the skin and allow like a better coverage of the implant, so you can camouflage the implant and have a more natural result. So that's what we quite often do actually in our cases.
Most of the time.
Yeah, exactly. It works quite well. But actually, yeah, the most important is for the patient to have like all the information she needs to choose herself the right reconstruction for her. And she needs also a surgeon that can offer all types of reconstruction, which is like most of the case in hyper specialized center or in breast cancer centers. So, yeah, so what's important is like don't hesitate to ask all the questions you want. You need to have all the information to choose well.
Yes, I loved your center because you do offer the exclusive lipofilling, and in the US it's less common, so it's interesting that that is more of an option in France, it seems like. That
Yeah,
is
it
cool.
depends on the countries. Actually, we really don't know why, because it's quite actually very simple. But yeah, it's a technique it's very well used. Yeah.
Perhaps because if you do exclusive lipofilling reconstruction, you need more surgery. Perhaps
Yeah.
it can be
Maybe it can be an issue
a part of the
other
explication.
yeah, or costs, maybe some cost issues. Yeah.
Good point. For the recovery process, all of those are different, right? So
Yeah.
I know, yeah. Do you want to go through that a little bit, like for each of those three options, what the recovery would be like?
Yeah, well, for the recovery, it actually really depends on the type of surgery. For like a regular lipofilling, it's 1 hour of surgery. Ambulatory, that means you can go home straight away after surgery on the day itself. Maybe like depends on what you do for work, but 1 week a bit calm, yeah, like sickly for 1 week. If it's a flap, whereas that's much more severe, you know, it's a longer surgery. So you need 1 month and a half at least to recover from that. There's lots of dressings to do, scar caring also. And the mix of it is the implant, which is maybe 15 days of sick leave and 2 hours of surgery. Or maybe Emily, you want to talk about your experience on
Oh
recovery?
yeah, I could talk about too. Yes, I did several steps because of what we decided on. So my first step, we did a reduction because that I forget why we did that. What was our reasoning for that? I don't know. We did
But
that.
it was well, in order to do a skin sparing mastectomy and to keep the envelope of the skin healthy, actually, or well vascularized, we need to reduce, not as much, but reduce quite well the skin envelope, because if we do the mastectomy with a very large breast, we have risk of skin necrosis and infection and all that comes with it. So reducing the skin envelope will allow us to have a nicer, like a skin, avoid skin necrosis. Avoid skin necrosis, yeah.
Yes.
Yes,
Okay.
because
That
the
yes.
vascularization of the skin
Yeah.
comes around
Yeah.
and deeply by the gland.
Yeah.
So when we do a mastectomy, we remove all the gland and all the vessels coming from the gland. So the skin live only on the vessels around. So if it's a big pocket, a big skin pocket, all the middle part can survive. It can't. So we need to
the blood
reduce.
won't come to that far actually. Yeah.
So we need to reduce the distance, and after the skin is better for a mastectomy and immediate recon.
Yeah.
Okay, yes, we did that. That makes total sense. I just totally forgot that whole part of the process. Then we did 4 months later, we did a double mastectomy with an expander for the reconstruction temporarily, which is basically like, I mean, I'm not going to explain it poorly, but kind of like an implant, but it's made out of, it's kind of like a pocket you can fill and decrease, which you can do it externally, which is cool. So like if you want to decrease it, they can go in with a needle and decrease it. So we did that. And then every 2.5 months after that for until November, I had lipofilling. So first we did my stomach and then my thighs and then my like hip area. So every time it takes about I would say like 2 weeks for like all the bruising to go away.
Yeah.
I think most of the time the pain was gone after like a day or two. I think the most painful one was the hip area at the end
Hmm.
because it kind of like the incisions are kind of by your butt. So I don't know, it's just kind of more like
Yeah.
difficult to sleep and stuff.
Yeah.
But in general, I think obviously the mastectomy is the hardest to recover from because you have drains and stuff like that. But ultimately, I'm really happy with the result. I loved that I doing lipofilling because it's permanent, so you don't have to do the maintenance of
For sure.
having implants and having to change them. And yeah, I kind of knew I wanted to do this all in one swoop in 1 year and then just be good for the rest of my life, hopefully. So yeah,
But
that was
what
my
is important
experience.
to say is that it's a long process. It's not like all in one.
Yeah,
It's like when we see Angelina Jolie with like she's nice and everything, you say, okay, that's easy
yeah.
to do a double mastectomy. It's great, but no, it's a very long process. Many surgeries. Sometimes we have complications, when we can lose
Hmm.
implants, lose the skin. So it's something that yeah, it's not nothing. So we really need to think about it.
And that's why the patient must know all the
Yeah,
information and must do their own choice
yeah,
of recon.
yeah,
That's true. That's true. I was lucky I had no complications or
yeah.
anything. But yeah, people do have complications. That's true. And yeah. Um, okay, yeah. What is the risk of cancer recurrence after treatment? I guess that probably depends on the patient potentially. I don't
Yes,
know.
it depends of variables, several factors, but the risk, the mean risk is like 15%. But if at the diagnosis of the cancer it was a little cancer without any involvement of the nodes, your risk of recurrence is less than 10 or 5%. If you have at the diagnosis an involvement of the nodes, the risk of recurrence may be like
The
20%.
the
The
nodes,
nodes,
not the
yes.
nose.
No, the nodes, sorry.
Lymph nodes.
The lymph
Yeah.
nodes. It may be 20%. So that's why the screening and the early diagnosis is
Mhm.
very important because the risk of recurrence depends of the diagnosis. If there is a little lesion, like 1 or 2 centimeters without any nodes,
The
the
prognosis,
liaison, the prognosis is very
very good.
good. It's like 95 without any recurrence. You
Mhm.
are cured. So it's very important to have an early diagnosis. The treatment are simpler. Most often you can keep the breast
Mhm.
when it's little, and you have only surgery and radiation and perhaps hormonal treatment, but no chemo. So it's very important an early diagnosis.
Mhm.
That's great to know. I'll add another question to that because I feel like people might want to know in the chat.
Mhm.
If you're doing this as a prophylactic surgery, so you don't have cancer, but you have perhaps a genetic predisposition, you either have a BRCA gene or family history or something, what can you tell patients a certain percentage that their risk reduces, or like what do you have like a ballpark number for that? Like if you end up doing the mastectomy, what would you say you can bring the risk down to?
When you do a prophylactique,
Yes.
à combien tu diminues le pourcentage?
It's like a 5% risk. And if you have a mutation like BRCA1, your risk of cancer is like 80%. So it's a very, very high risk. It's a lifetime risk, 80%.
So 80%, you bring it down to 5%.
Yes.
Yeah.
Okay, it's not zero. It's never zero because when you remove the gland, you can't remove all the gland. There's little cells
Mhm.
under the skin, and one day these little cells can give a cancer. So it's not zero, but it's very low, the
Mhm.
risk.
Yes, and I want to say the general, I mean, you guys will know more than me, but the general population risk for women without a mutation, I think, is like 12 or 13% or
Yes,
something like that. So
yes,
you're getting below at even like the general population, which is nice.
Yeah.
yes.
Mm.
But
Cool. Do we want to go to the next slide? You can keep talking if you want.
What do you want to say?
no, no, I just want to say for BRCA patients, we have to take care of ovaries too.
Yeah, yeah.
So the often, thanks to Angelina Jolie, we speak about the breast, but for the patient with a mutation, the most important can be the ovaries because the cancer of the ovaries is worst. And so it's important to speak about breast, but think to the ovaries too.
Yeah. And what
Yes.
do you start a mastectomy or ovariectomy? For each, what age is it recommended to do that?
30 for mastectomy, and for ovariectomy, it's like 40 for BRCA1 and 40 it can be after for BRCA2, like 45. But don't forget, because the mortality of the ovaries cancer is very high.
Yeah.
I saw that they're developing a vaccine in the UK for this that they're hoping to roll out. I mean, hopefully it rolls out in the next like 10 years or something. Have you been watching that or no? I don't know. We'll see.
We don't know exactly for the moment, but I heard about that.
Yeah, maybe it's a bit early.
Yes.
Yeah, I think they're just trialing it, but good to have options. Well, if anyone has questions, this is a great time to ask them if you want to. And I don't know if that you want to put it in the chat. We'll give you like a minute or two, or you can, yeah, if you want to do that. Otherwise, we have a link to our website, Instagram, the Institute site, and some more information from the cancer centers. And thank you so much for your time. This was so informative.
Yeah,
and
nice. Thanks. Nice seeing you and seeing all of you. And thanks for your time, yeah.
Oh, someone said not a question, but thank you for organizing. Oh, okay, thanks.
Well, what we can say maybe is that we are all very available. If you have any questions, you can address them to us by mail. You know, you can go on the website and or ask for a direct mail. So we even though you're anywhere in the world, you can ask us questions by mail. No problem. We'll answer that.
Hello.
Thank you so much.
I just have a question.
Should we start the process younger if we have a strong family history?
What process?
The process like of maybe screening and
yes, the screening is before 50 if you have a family history.
Yeah, before 50.
Before. It's depending of the age of the diagnosis of the family. If it's very young, we can start younger, yes.
Yeah.
But it's a personalized screening after. So it's depending of the history. You have to talk with your doctor.
Okay, Merritt has a question for both surgeons. You can unmute if you want to say it, or you can put it in the chat. It's up to you.
Oh, hi. Can you hear me okay?
Yes.
Yeah.
Oh, awesome. Thank you so much. Hello. Thank you so much for this. I really appreciate it. I have a couple questions. I'm just curious. Let's see. So last year I had a double mastectomy, direct implant surgery in New York. And I'm just curious, what is the standard of care in France for follow-up monitoring for mastectomy patients in terms of MRIs and ultrasounds? How often, if at all, do you guys recommend doing that?
Once the mastectomy is done, right?
Pardon?
Once the mastectomy is done, what is the regular exams? Is it?
So after a double mastectomy, in the future, for MRIs or ultrasounds to monitor any sort of reoccurrence, what is the standard of care in France?
Well, in France, it's one a year, one MRI or echography per year.
Even after a double mastectomy?
Yeah, that's what Jenny said. Yeah. That means we will take out most of the mammary gland out, but we can't take 100% out, even though we remove the skin actually. So it's to check those little cells that are left that may develop cancer. That's one point, and the other point is also to check the implants also if there's any rippling or rupture. So it's for both. Especially for the cancer detection, that's very important. You still need to continue those exams annually.
So the MRI, is that different from echography that you just said?
Yeah,
It's depending of the cancer first. If it was seen by ultrasound or by MRI. If it was by MRI only, we still continue MRI. If it was by mammogram and ultrasound, we can do only ultrasound once a year. So it's depending of the diagnosis first. But it's not a recommendation.
yeah,
It's like a security because we can't remove all the gland.
yeah. So ultrasound, you continue, but mammograms, you don't need to do it.
No,
Yeah.
no mammogram.
No mammogram.
But we can do a mammogram on an implant,
Yeah,
okay?
exactly.
But only if there is a target on the ultrasound. We don't start by a mammogram first. We start by ultrasound or by MRI, depending of the diagnosis.
Oh, okay, thank you. And so I know to monitor the health of the implants, you would do MRI without contrast, but to monitor any potential reoccurrence, it would have to be an MRI with contrast.
Yeah.
Is that correct?
Yeah, yeah, with contrast.
And so you in France, the standard of care is to do that annually?
Yeah, once a year.
Even after a double mastectomy?
Yeah.
No, it's not a standard.
We do it.
We do the breast specialists do most of them do once a year, but it's not a recommendation in France. There is no recommendation after mastectomy, but we know a recurrence can happen, and we know if you had a double mastectomy, it may be because you had a mutation or both cancer, or I don't know your history, but you are supposed to be at high risk. So it's better to have a follow-up.
Okay. Okay, thanks for that. And then so let's see. So do you do so one of you is a breast surgeon and one of you is a plastic surgeon, is that correct?
Yeah.
And
We
so
do
do you
both.
Yeah.
We do both, but first we are a gynae and a plastic, but now we do both. Yes.
Okay, and so do you do team mastectomies and do you do nerve sparing or resensation work during the mastectomy where the breast surgeon opens the breast and then the plastic surgeon, microsurgeon folds the nerves in like a wet sponge and then tucks them in the body so that while the breast surgeon is removing the breast tissue, then the microsurgeon, plastic surgeon can either reconnect or graft the nerves. Do you do that?
No, we don't do that. The nerve grafting, well, there's quite some publications on it, but doesn't really work that much, especially if you have radiotherapy afterwards and everything. Healing process is a bit longer, but no, we don't do that here.
So you don't do nerve grafting. What about reconnecting the nerve, the intercostal nerve after the mastectomy? Do you do that to try to preserve any sensation?
Well, the intercostal nerves, when you do a proper, actually, a mastectomy, you take it out. So the skin will not, you don't have like a huge nerve, like a facial nerve to reconnect like that. The nerves of the breast skin there's many of them, so you're not going to reconnect like all those 1,000 nerves that you have. So yeah, we don't perform it here. Maybe it can be in other centers and other countries, but here in France, I don't think so. Yeah.
Okay. And then I just have one other question. So I had 6 millimeters of ILC. So my final pathology revealed that I had 6 millimeters of ILC, invasive lobular cancer, and then I had 10 millimeters of DCIS, and then 5 millimeters of LCIS pleomorphic. What website can I go to help me understand the standard of care in France for the margins that have to be achieved during a mastectomy for those particular cancers?
The margins for the cancer.
Or is it just a general rule?
Maybe after lumpectomy will be actually when you take a mastectomy, the margins are the breast. So that
there is no margins if it's a mastectomy because we remove all the breast. But if it's a conservative treatment for invasive cancer, it's free margins, just free. There is no limit. And for DCIS or other for in situ, it's 2 millimeter if we keep the breast.
So if you keep Well, so for a mastectomy, though, so if the pathology report from the mastectomy reveals like no tumor on ink for the
Yeah.
ILC, would that be considered okay?
Yeah.
Yes.
Yeah.
All right, that's all. Thank you so much. I really appreciate it.
No problem. Pleasure.
Thank you for your question. We have two more
Yeah.
really quickly. Someone asked if they need genetic testing for BRCA or other mutations.
Do I
I
need
think that depends on your family history and kind of your own choices. I don't know what you guys would say about that.
oncogénétique?
For the oncogenetic
Yeah.
testing,
Mm.
it's with a genetician specialized in genetic, a doctor specialized in genetic, and we do when there is a family history, like 3 cases in your family, and especially if we see the case are younger and younger, we will recommend to do a genetic testing. There is other case depending of the type of the cancer. For example, for triple negative, we systematically do the research, whatever the age of the patient. We don't care of the age just because of the type of cancer. And another indication, so there is the family history, there is the type of cancer, and there is the age of cancer. If it's before 30, we will do this research to know if there is a predisposition to do breast cancer.
That's perfect answer. Okay, the last question is, what are the recommendations for screening if a male has BRCA2? And are there even any preventative surgeries that men could have or no?
No, it's the exam, the self-exam, the exam by a doctor each year. There is no prophylactic mastectomy recommend, and there is no mammography, but we have to be very careful. And if there is something palpable, do a mammogram and ultrasound because it's possible even for male patient. And they ask to follow up also the prostate. It's more for BRCA1, but there is a specialty for male patient.
For like prostatic cancer.
Yes.
Okay.
Yes, okay. And then the last question, oh, there's two. Okay. Okay, someone asked if after fat grafting, do you have any advice for helping retain the fat? That's a good question.
Yeah, well, after fat grafting, you shouldn't have like any compression on the fat grafting area. You can like chase the fat away. So no compression, no sports also because that can move a little bit too much for at least 1 month. So yeah, and what is one also idea that the false idea that we have is that the fat will lose you will lose fat volume progressively. Actually, it's not true. When you do fat grafting, you will inject like 100, let's say 100% of the fat. And what will decrease is what the inflammation, the edema, some fat, of course, and the blood loss. Past 3 months, the fat that you will retain will be there for life, actually. So there's so that's very important. So you don't need to do that like every 10 years. Yeah.
That's good to know. Yes, I feel like people have so many questions about that because
Yeah.
it's complicated. But it's good to know after 3 months, you're like, this is good.
It's yours.
I'm sticking with this. Yeah. Okay, good to know. And then last question. Oh, there's two kinds. Okay, perfect. If a preventative mastectomy due to BRCA2 is done, what is the recommended follow-up screening in France? My mom is asking that, so that's specific to me, I think.
Oh, it's Lori.
No.
Hi, Lori.
Yeah.
We try to answer before. There is the recommendation. The recommendation, there is no recommendation for ultrasound or mammography or MRI. Okay, but we know if you are at high risk, and furthermore, if you already had a cancer and you have implants, it's better to do a simple ultrasound. It's very simple. It's not painful. So to check the residual gland and to check the implant. So it's not a French recommendation. It's
an exam that it's worth doing.
Yes.
It's worth doing like 15 minutes once a year just check it out, actually.
Yes.
Sure.
Okay, last question. What website do you recommend for standard of care in France and for breast cancer follow-up monitoring? Is there like a resource you guys reference for that or no?
Oui, il y a la Ligue contre le cancer qui est pas
Ouais.
mal. Yeah, well, I think you wrote it down. It's la Ligue contre le cancer ou l'Institut national du cancer. Actually, you can find it quite everywhere, and also in our website. Also, we have that. So that's general information that you can find quite often everywhere.
But don't forget, for me, there is the recommendation.
Yeah.
It's important to follow the recommendation,
Mhm.
but it's not avoid us to think about your case and your personalized case. Okay. So if there is any doubt, if the cancer was how to diagnose first, if there is a big history in your family, we can add some ultrasound or mammogram or MRI. It's a very simple exam and can cure you, cure you, sorry, and save your life. So we can add some little exam.
Personalize the treatment.
Okay, perfect. Thank you guys so much. Thank you for all of the really good questions.
Yeah.
We're happy to send around the recording if anyone wants, or if you have if you have another question later, feel free to send it to our Instagram listed there and we can pass it along to the surgeons, or you can find them on their website. Yeah.
That's a good thing. Yeah. On your Instagram account, you'll just forward to us all the questions, no problem.
Okay, perfect. Thank you guys so much for everything. We really
thanks,
appreciate
Emily,
it.
and your team also for organizing all of that, and good luck on your projects.
Thank you so much. Have a great evening for you
bye-bye.
guys.
Bye.
Bye.
Thank you very much.
Thank you.
Thanks.
Bye.